welcome to another session on pathology. And today we are going to do a very important topic in pathology. And this topic is asked in each and every exam which you will encounter in your pathology subject is concerned. Starting from the prof exams to your NEET PG. This topic will be there in every exam. Okay, glomerulonephritis is a very important topic, and it is a big blunder to skip the topic, right? So that's it. Glomerulonephritis is a very big topic. It has various etiological agents, various microscopy is different, the immunofluorescence is different, right? And the etiological agents, the pathogenesis, the all things are different things. Okay, all things are different. That's why what I have done is that we'll deal this topic in this way in a mind map format, right? So here we took 2 pages. Just open your copy like this and draw this. Okay, draw this table. In this table only, we'll finish this glomerulonephritis in total. Okay, we'll finish this glomerulonephritis in this whole table only, and there'll be no special point remaining in your Robbins textbook if glomerulonephritis is concerned after this. Okay. So glomerulonephritis can be classified into various like types. One is the membranous glomerulonephritis, Goodpasture syndrome, post-streptococcal glomerulonephritis, that is PSGN. Minimal change disease is there. IgA nephropathy or Buerger's disease is there. And then we have the MPGN spectrum of diseases like MPGN type 1, lupus nephritis, MPGN type 2, or C3 glomerulonephritis. And lastly, we have rapidly progressing glomerulonephritis, that is RPGN, right? So this is the whole spectrum of disorders which are there in your glomerulonephritis. And after this, let's start one by one, and we'll first see the etiology. Okay. So first we'll be starting with membranous glomerulonephritis. Okay. I'll write in 9. Be easy. Etiology. So membranous glomerulonephritis. So what is the etiology behind the membranous glomerulonephritis? Majorly remember it is antibody against the PLA2A, PLA2R. Sorry. Okay, PLA2R means phospholipase A2R receptor. Okay, so it is an autoimmune disorder basically. Autoimmune disorder that is antibody against the phospholipase A2 receptor. Okay, so first etiology is your antibody against phospholipase A2. Antibody against phospholipase A2 receptor. Phospholipase A2 receptor. Okay, then some drugs may cause this disorder. Some drugs which were used earlier in some rheumatoid arthritis like conditions, also in SLE and other conditions. Okay, drugs like penicillamine and gold may cause this condition also. So drugs like gold and penicillamine may cause this condition. Okay, some infections like hepatitis and SLE, some diseases like SLE, hepatitis may cause this condition. Okay, and now this much you remember. Okay, on the no need to go into much details into the etiological agents. Okay, okay. After the etiology, let's come to the second important thing, that is the pathogenesis of this disorder. Okay, after the etiology, we will come to the pathogenesis of this disorder. So, what is the pathogenesis? Okay. So if I talk about the pathogenesis, what happens is that there will be nephrotic syndrome here. If you don't know the difference between nephritic and nephrotic syndrome, do go into the Robbins and read the differences between the nephritic syndrome and nephrotic syndrome, because it is important from point of view. But I am taking the class on your glomerulonephritis, so I will assume that you have a good idea on the differences between nephritic and nephrotic syndrome, where hematuria is present, where it is absent. Where what is happening, the pathogenesis basically you must have known. Okay, so normally what happens, let's say here we have our cells of the renal system. Okay, the podocytes and all. Okay, and if, let's say the phospholipase A2 receptor is normally present. Okay, phospholipase A2 receptor is normally present. So what happens? The antibodies against the phospholipase receptor, let's say it is an antibody, this is a receptor, so it will bind to the phospholipase receptor and destroy the antibodies. So basic pathogenesis is that if this is a phospholipase A2 receptor present over here like this, if this is the PLA2 receptor here, okay, then some antibodies will be going there. Let's say this is the antibody and it will bind and destroy it. Antibodies bind and then they destroy it. And the syndrome here will be nephrotic syndrome. Nephrotic syndrome. Okay, this nephrotic word is important. Just make sure to highlight it. Nephrotic syndrome. Understood? This is the basic pathogenesis. Then let's come to the microscopy of this disorder. Microscopy. So what will you see in microscopy? Just think. What will you see in the microscopy? So antibodies are there. So antibodies will, what are the antibodies? Proteins. So proteins, how they appear in microscopy? Pink color. Right, understood. So there will be an increase in the pink color, increase in eosinophilia or pink color. So proteins will appear pink in microscopy, and the glomerular capillaries will be thickened. The glomerular capillaries will be thickened. Okay. So here the microscopic findings importantly are two things. Proteins will appear pink, and second thing is that there is a thickened glomerular capillaries. There is stain done here. It is called a silver stain, and the appearance characteristically is called spike and dome appearance. There is a characteristic appearance associated with this condition. It is asked in your MCQ exams. If you do Warden silver stain, and increasing the font and writing, spike and dome appearance. Spike and dome appearance, and this is a characteristic appearance associated with this condition, right? Okay. Let's come to in kidney. Whenever we talk about the electron microscopy, right? We don't miss the immunofluorescence, electron microscopy and immunofluorescence. Whenever we talk any disorder in kidney, right? So just erase this. It will be difficult if I slide it. Okay. So here we are taking immunofluorescence, IIF, immunofluorescence. I'm leaving space and writing because we have to do a wide range of conditions, right? To do this much of diseases. I'm using much space, giving spaces. Okay, IIF, immunofluorescence. So what will happen is that this is the epithelium. This is the epithelium, like this one. This is the epithelium. This whole part is the epithelium, and here in the end, this is the endothelial layer starting over here. From this, and the endothelial layer will continue. So there will be, if this PLA2 receptor is present in patchy format, discontinuous format. Okay, so there will be some epithelial deposits. There will be some epithelial. Look, this part. This part is subepithelium, right? This whole part. Just pay attention. This whole part is subepithelium, right? Subepithelium. So there will be subepithelial deposits. Okay, and that will be a in a discontinuous fashion. Subepithelial deposits in a discontinuous pattern, which will be giving a granular appearance. So here we tell that it is a granular positivity present over here. Okay, so immunofluorescence, you have to know that if this is the epithelium, and this is a subepithelial space, and then our endothelium will continue from here, and the endothelium which will be continuing. Okay, this is the endothelium. So this PLA2 receptor is present like this in a patchy format. So the deposits here will be like patchy. Okay, so there'll be patchy. Let's write it in green. Patchy subepithelial deposits. Patchy subepithelial deposits, and this will give a characteristic granular positive. This term is important. Granular positive, right? After this, after immunofluorescence, we'll see what? We'll see electron microscopy, right? And electron microscopy, what you'll find? Subepithelial electron dense deposits. Clear? Electron microscopy will do, and we'll observe electron dense deposits, right? And then will write special points, and there are no such special points which you have to remember in this disease. Okay, in other disorders, there if a classification is there, if any other aspect is there, if any other important point is there, we'll add to it. Okay, so this is the etiology. Let me give some space over here. So special points, I'll start to this here. Electron microscopy. Done? Clear? Okay. Let me categorize here like this. Just a minute. I will suggest you all to make the table as it is in your copy itself, so that it will be easy for you to revise. Okay, done. Okay, so we finished our membranous glomerulonephritis, and then we'll go to the Gould-Pasture syndrome. Now we have our template ready. We'll just quickly go through the disorders again. So up to now, you must have figured how we are going to clear this topic. How we're going to approach this topic in a mind map format, and this mind map will be important at your time of exam. So you have to compare and contrast. This compare and contrast method is basically very helpful in revising the stuff which you read in a discrete format, and you can do this method with all of this. Okay, like glomerulonephritis, you got glomerulonephritis on one page. That's amazing, and it's a topic of 14-15 pages, and you could concise it in one page, then it's more than good. Okay, no need to any that be tensed in the exam, right? You got it all right. Okay, let's start with Gould-Pasture syndrome. Here, Gould-Pasture syndrome, there's an etiology is that the antibody against the collagen 4, collagen type 4 is formed. Antibody against the collagen type 4 is formed, which will destroy the glomerular basement membrane. Okay, so the etio is, and one etiology is there only, antibody against collagen type 4 will destroy glomerular basement membrane. Okay, understood the etiology. Let's move to the pathogenesis of the Gould-Pasture syndrome. Pathogenesis. So, what is the etiology of? We'll revise with this membranous glomerulonephritis antibodies against the PLA2 receptors. Antibodies against the PLA2 receptors. Some drugs may be causing like golden penicillamine, and some diseases may be causing like SLE and or hepatitis. Right. Here, good pasture syndrome etiology is antibody against collagen type 4, which will destroy the glomerular basement membrane. Right? Talk about pathogenesis. So pathogenesis is that the antibodies will bind to the glomerular basement membrane and will destroy the glomerular basement membrane, and there will be nephritic syndrome present over here. Which syndrome? Nephritic syndrome. Here, what syndrome was there? Nephrotic syndrome, right? So here there will be nephritic syndrome present over here. So if I talk about the pathogenesis, then if this is the epithelium, this is the glomerular basement membrane. Let's zoom it GBM, and then this is the endothelium. So antibodies will bind here and destroy the GBM. It will bind and destroy the GBM, and this will cause nephritic syndrome. Nephritic syndrome will be there. Okay, nephritic syndrome will be there, and here the lung may be involved. If there is lung involvement, then we'll see the clinical features. Clinical feature will be hemoptysis if lung involvement. If lung is involved, then will be hemoptysis present over here, right? Okay. We talked about pathogenesis. Pathogenesis is done. Okay. Let's move to the microscopy quickly. Microscopy. So, what we'll see in the microscopy? Answer me. Same thing, right? Same thing. Let's take green color. Okay. So, microscopy, there will be same capillary thickening. Then no special thing. There will be same capillary thickening present over here. Okay. Same as membranous glomerulonephritis, the same capillary thickening will be there. Okay, no such other things present. Then immunofluorescence. Let's move to the immunofluorescence. So in membranous, you have to remember the spike and dome appearance, which is a characteristic appearance, and don't forget this spike and dome appearance, which will be seen on Warthin silver stain. Okay, immunofluorescence of this disorder of this good pasture syndrome. So what will be the immunofluorescence? If the immunofluorescence, that the secondary antibodies, and to the antibodies the secondary antibody will bind, and secondary antibody will have a immunogenic substrate. This is the basic concept, right, behind the immunogenicity. Okay, but this receptor, this binding of this antibody is continuous. It was patchy. It was patchy. The PLA2 receptor was patchy in the deposition, but this is very continuous here. If this is continuous, there will be linear positivity. There will be a linear positivity. Understood? So here, what I am saying is that, let's say this is the thing. This is the glomerular basement membrane. I'm drawing it a little bit down so that you can understand. And this is the endothelium. Here, our antibodies are bound. But once you do immunofluorescence, there will be secondary antibodies which are going over here. And this is present in a continuous format. Continuous. And here to this, something green substrates are being green color I am taking because it appears green on a dark background, right? Immunofluorescence. That's why. So it is continuous. Remember this statement. So if this is continuous, there will be linear positivity. Linear positivity. Linear positivity. Understood? So granular positivity is seen in membranous glomerulonephritis. In good pasture syndrome, a linear positivity is seen. Just make sure to understand here. Okay. So there is intramembranous on the glomerular basement membrane. So there is in intramembranous deposition of the intramembranous deposit. Intramembranous deposit. Understood. And this intramembranous deposit, the very special point is that it is not seen on electron microscopy. It is not seen on electron microscopy. So just remember this, on electron microscopy, this is not seen. This is again a special point. It's not seen. So we are done with the two disorders. We are done with membranous and the good pasture syndrome in a contrasting way. Okay. And now we are going to our post streptococcal glomerulonephritis, or the post infectious glomerulonephritis, or the post infectious. glomerulonephritis. Okay, so the etiology is that this can be due to your upper respiratory tract infections, or this can be due to some skin infections like impetigo. Any skin infection or by your group A streptococci are called as impetigo, right? So this may be due to impetigo, this may be due to upper respiratory tract infections, due to which the antigens will be planted on the glomerulus. Okay, and there will be an immune response. This immune response will destroy the glomerulus fully, and the characteristic clinical feature is the cola colored urine. I'm seeing flavor. Okay, cola colored urine. Okay, so post streptococcal glomerulonephritis. What is the etiology? So the reason, this may be due to upper respiratory tract infections, or this may be due to some skin infections like impetigo. Skin infections like impetigo, due to which the antigens will come to the blood. Let's say this bloodstream, this the antigens have arrived, and this antigen, if they are planted on glomerulus, they will destroy it. Due to an immune response, there will be glomerular damage. Okay, there will be glomerular damage. Right? So, what is the pathogenesis? Again, same thing. I told you in etiology itself, but let's say we have pathogen column, so I'm writing it. Pathogenesis. So pathogenesis will be that, let's say we have a streptococcal antigen, because this is post streptococcal glomerulonephritis, right? So basically this antigen, why this is called post streptococcal, but it is not called streptococcal glomerulonephritis, because whenever the antigen comes to the blood and to the production of this cola colored urine, destroy and cause a characteristic cola colored urine. This is important, so remember, cola colored urine. To the appearance of this cola colored urine, that takes some time. Takes some time, and this time is a lag period 1 to 4 weeks. This lag period is 1 to 4 weeks. That's why after the infection, after 1 to 4 weeks of infection, there will be this production, right? So streptococcal antigen will be deposited in glomerulus anywhere, most commonly in subepithelial space, but it can deposit anywhere. Just remember this statement. Okay, so pathogenesis is that streptococcal antigen will be deposited anywhere. Just a minute. I was telling that it can deposit anywhere. Okay, let's say there's the most it can deposit anywhere. Can deposit anywhere, and if this can deposit anywhere, but the most common site is your subepithelial. Okay, most common site is subepithelial, but it can deposit everywhere. But if it is deposited, then either there may be an antibody production where IgGs will predominate, either there will be a complement activation. There will be classical complement pathway activation, right? And this will cause the production of, let's say, C3A or C5A, okay, which are extremely chemotaxic. C5A is extremely chemotaxic, so it will be bringing the WBC to the damaged glomerular membrane. Okay, and there will be a nephritic syndrome associated with it. Nephritic syndrome, importantly. Okay, and there will be hematuria as well. Understood? And this WBCs can be also seen in the microscopy. Okay, so very easy and important. It is easy, very easy. It can deposit everywhere, or it can cause a antibody production either, or it can cause the complement activation, classical pathway, complement pathway. Okay, classical complement pathway. And if this occurs, if antibody is produced, then there may be IgG or IgM. And if there is an classical complement activation, then it will stimulate the production C3A, C5A. Okay, this will bring WBCs, and this WBCs They will be seen on the microscopy, and this will lead to a nephritic syndrome, and there will be hematuria present. Any nephritic syndrome will produce the hematuria. In nephrotic syndrome, there is no hematuria. Okay. This is the basic pathogenesis of your post-streptococcal glomerulonephritis. Let's move to the microscopy of the post-streptococcal glomerulonephritis. So, of course, there will be glomerular capillary thickening associated with this also. So, if I come to the microscopy, then there will be same finding, capillary glomerular thickening, take green color. There is glomerular capillary thickening, as well as WBCs will be there. WBCs can be seen. WBCs will be seen inside the glomerulus. Okay, so there will be endocapillary hypercellularity due to this kind of disease. Okay, so the term is called endo. Endo means inside, capillary, endocapillary hypercellularity, because there is an increased number of WBCs. Hypercellularity. Endocapillary hypercellularity. And this is a classical finding. Okay, plus there will be, due to increased filling, the glomerulus is like a bag like structure. The increased filling, there will be a slightly enlarged glomerulus as well. Okay, the size of glomerulus will increase, thus there is an enlarged glomerulus. And this increase in WBCs is responsible for an enlarged glomerulus. After that, let's come to the immunofluorescence, IIF. So what is what will be the classical findings in the immunofluorescence? So immunofluorescence will have granular deposit along the capillary wall, granular deposits along the capillary wall, and the IgG will be deposited, the C3 will be deposited. Okay, you can in Robbins one line is written that due to the C3 deposit, due to C3 deposit, serum C3 levels will also reduce. Okay, so that's the finding. And here we tell that it is a lumpy bumpy appearance. A lumpy bumpy appearance is a characteristic finding. There will be granular positivity along the capillary wall. Granular positivity along capillary wall. This is the main thing. Granular positivity along capillary wall. Deposition of what things will occur? Deposition of IgG, IgM, C3 deposition, and this type of thing is called as a lumpy bumpy appearance, which is important from this point of view. Okay, a lumpy bumpy appearance. Understood? Then let's come to our electron microscopy. In Goodpasture syndrome, there is no electron microscopy. In a membranous glomerulonephritis, what was there? The finding. There were subepithelial deposits, subepithelial electron dense deposits. Here, the electron microscopy will be have a lumpy heap of depositions. As depositions are there, from predominantly subepithelial. Okay, there or they may be intramembranous as well. So, the thing is that there may be a lump of deposits. A lump of deposits means that you can find. Just a minute. Camera. Is it visible? Yeah. Okay. So I was telling that there will be lumpy heap of depositions there may be seen. Okay, so here you will see a lumpy heap of deposits. A very lumpy heap of deposits. Predominantly, they may be subepithelial or intramembranous. There may be subepithelial deposits or intramembranous deposits. Understood? Then, another thing is that the electron microscopy in special points, I will write that it is a self-limiting disease. It is a self-limiting disease and it will resolve soon. It will resolve soon. So the treatment is basically supportive treatment only. Okay. So that completes our post-streptococcal glomerulonephritis. Post-streptococcal glomerulonephritis, and then we'll move to our another disease which is called as a minimal change disease. Minimal change disease. Okay. So talking about minimal change disease, the etiology. What is happening? Okay. Etiology. Okay. So we can have a variety of etiologies associated with this condition, but minimal change disease has a number of special points associated with this disorder. Okay, very special points are there in this disorder. Like, let me go to the special point column and write these points, special points. Remember that this why it is important why we are reading this, because it is the most common cause of nephrotic syndrome in children. Most common cause of nephrotic syndrome in children. It is the most common cause of nephrotic syndrome in children. Okay, and a child with massive and selective, you can say, proteinuria. Okay, and there may be some edema present, like puffiness or periorbital puffiness or edema. Okay, so diagnosis will be the minimal change disease, and the steroids can cure this disease in almost 95 to 99% of patients. Okay, steroids can kill that you know cure this disease. So treatment aspect, just a minute. Okay. So I was telling that the treatment is basically steroids. Okay, you give steroids and the disease will be cured. Understood? So that was some special points, and now we're coming to the etiology of this disorder. Okay, what are the etiologies which can cause this disease? So this disease may be caused in a variety of etiologies where there is activation of interleukin. So major thing is that the interleukins are activated. So you have to activation of interleukins. And this activation of interleukins may be brought about by various conditions. There may be some drugs, there may be some steroids, okay, some bacteria, some virus, some fungi. Okay, some bacteria, virus, fungi may cause this condition. Okay, the risk factors may be HLA, like the predisposition, any HLA predisposed individuals, any allergic condition, any upper respiratory tract infections. Okay, just don't know what happening. It is crashing repeatedly. Just bear with me. Okay. Drugs, steroids, bacteria, virus, fungi, HLA predisposition. I was telling allergic conditions. Some allergic conditions may cause this disorder. Hodgkin's lymphoma also can cause this disorder. Okay, so Hodgkin's lymphomas may cause this type of disorders. Okay, understood. So this is the etiology, and etiology means that there is what is the Pathogenesis is very simple. Pathogenesis is basically there is an activation of interleukins, and this all etiologies which I wrote will cause an activation of the interleukins, and this activation of interleukins will go on and destroy the food processes of the glomerulus. Will go on and destroy the food processes of the podocyte cells, right? Basically. Okay. So the pathogenesis is very easy. Activation of interleukins, and this interleukins will go and destroy food processes. Go and destroy the food processes. Okay, this is the thing. This is the basic pathogenesis. Okay, and what about the microscopy? Let's see about the microscopic findings. Microscopy. Green color for microscopy. Okay, so see. Here, the food processes are damaged. The food processes are damaged, and the food processes are not seen on light microscopy. This food processes, this one, is not seen on light microscopy. Remember this fact. Not seen on light microscopy. So what will happen is that in the microscopy, the glomerulus will appear entirely normal. So entirely normal glomerulus. There is an entirely normal glomerulus present over here. Okay, since there is a, you know, lipid nephrosis. Okay, lipid nephrosis. Lipid nephrosis means there is lipiduria here. There is lipiduria present over here, and PCT will absorb the lipids. So the PCT cells, if you observe, will have some clear vacuoles present. Okay, so then we call this term as lipoid nephrosis. Lipoid nephrosis, and this is a non-specific finding. It is seen in almost every nephrotic syndrome. So here also you'll have seen lipoid nephrosis here. It was also a nephrotic syndrome. So here also you would have seen lipoid nephrosis. So let me state here only in microscopy. Okay, the PCT will show clear lipid vacuoles, and this is called as lipoid nephrosis. Understood? Done? Okay. After that, the immunofluorescence. As in the glomerulus is entirely normal, right? What you'll find in your that immunofluorescence? Nothing. Immunofluorescence is negative still. A big negative. Negative. Okay. In your membranous glomerulonephritis, it was granular positivity. In your good passer syndrome, it was linear positivity. Okay, and then we talked about your post-streptococcal glomerulonephritis, where it is again granular positivity, but lumpy bumpy appearance. Lumpy bumpy appearance is important. Don't forget. Okay, just put stars here. Lumpy bumpy appearance, and here in your minimal change disease. In minimal change disease, it is immunofluorescence is negative, straight negative. Okay, and if I talk about the electron microscopy, you will see effaced food processes. In electron microscopy, what you will see? Effaced food processes. So effaced food processes. Okay, understood. So that was about our discussion, and then we will talk about a disease, a very very important disease, which is called as the IgA nephropathy. IgA nephropathy. So we are moving to our next condition called IgA nephropathy. And IgA nephropathy is also known as Buerger's disease. Okay. Okay. Just a minute. Okay, Buerger's disease. So what happens is that IgA, IgA is a mucosal and immunoglobulin. Okay, so it will increase the mucosal pathologies. Understood? So IgA, whenever there is an increased level of IgA in the serum, okay, so the liver will remove the excess of IgA molecules. Okay, 85%, 100 molecules of IgA are produced. Then 85% will go to the circulation, and 10 to 15% will destroy the pathogens. But increase IgA in serum, if it happens, then the liver will remove the excess IgA. So here the etiology can be a primary etiology, or it may be a secondary etiology. Primary etiology or a secondary etiology. So what is the meaning? What is the meaning? Primary etiology. So primary etiology is that if a glycated molecule of IgA is produced, okay, if a glycated molecule means that it is an abnormal molecule which will be escaping the removal system by the liver. So it is not removed by liver. So primary etiology is that an abnormal IgA molecule. Abnormal IgA molecule is produced which escapes just gives the liver, and can deposit in the smaller vessels only glomerulus, or it may have a systemic involvement also. So systemic involvement is called as the Henoch's choline purpura. Okay, let me go to the special point column and write this. So in Buerger disease with systemic involvement is called as Henoch's choline purpura. And not calling purpura, because it may be that deposition may occur in the vessels, right? So this is the Buerger disease, and there may be a secondary etiology, that is liver failure. If there's failure of liver, how it will be excreted out, right? So liver failure. So two etiologies: one is the primary etiology or abnormal IgA, or the secondary etiology, that is liver failure. Okay, so what is happening basically in the pathogenesis? We'll see in the pathogenesis column. Just a minute. Did I write etio here? No. Then come to pathogenesis. So this IgA molecule are deposited in the mesangium. It's deposited in the mesangium. Okay, due to which the complements and all things are coming here, and this activates the alternate complement pathway. This activates the alternate complement pathway, due to which the molecules produced are like C3, C5A. C3 is producing maximum numbers. Will stimulate chemotaxis also, and WBC may deposit in the mesangium, and this WBC deposit in the mesangium will destroy the glomerular basement membrane and will cause nephritic syndrome again. Okay, there will be hematuria. Easy, very easy, right? Basically, all the glomerulonephritis, you can see slight variations are there. That's why I'm taking a column, but the mechanism of action is just the same. There is some inflammation happening, there is some destruction, and nephrotic or nephritic syndrome as characterized. And if there is the there is a damage of the glomerulus, syndrome is always nephritic syndrome. So nephritic syndrome is saw here also in your PSGN and good pasture syndrome. There is nephritic syndrome, right? There is nephritic syndrome, and here also there will be a nephritic syndrome. Understood? So let's discuss the pathogenesis here. Just a minute. So in pathogenesis, there is a IgA, increase IgA, and this IgA is deposited in mesangium. Okay, let's say yeah, and this is the mesangium. This diagrammatic representation is important. That's why I'm drawing it. And by this, there is an infiltration. There's an infiltration if the IgA molecules are deposited over here, IgA. There is an infiltration of C3 and C5a. Okay, so there is a activation of alternate complement pathway. This alternate complement pathway will bring C3 and C5a. There will be chemotaxis. There will be WBCs which will be coming and destruction. So there will be nephritic syndrome and associated with hematuria. So here nephritic syndrome is there, right? Understood the pathogenesis? Very simple pathogenesis, right? Okay. So what about the microscopy? Just guess. What about the microscopy? I guess you all have become experts now in this glomerulonephritis topic. Green color, right? For microscopy. Okay. So in WBCs are coming in the mesangium, so there will be mesangial hypercellularity. WBCs are coming in the subepithelium, so there is subepithelial hypercellularity. WBC is coming in the capillary, so there is endocapillary hypercellularity. This endocapillary hypercellularity and lumpy bumpy appearance is characteristic of your PSGN, right? So that's why in the microscopy what will happen, there will be WBCs in the mesangium. Okay, WBCs in mesangium. Okay, so there will be mesangial hypercellularity. That is mesangial hypercellularity. Mesangial hypercellularity plus mesangial widening also. If there is hypercellularity, some cells are coming, then it will get widened, right? So there will be mesangial widening also plus. Second point you can write. Mesangial widening. That's about microscopy. Then we're talking about the immunofluorescence. So what will happen in the immunofluorescence? Just see. Okay. In the immunofluorescence, there will be a mesangial positivity present. There is linear deposit. There is linear deposit, but there is a mesangial positivity because the IgA molecules and the C3, the other proteins, these are coming to the mesangium. Okay. So in the immunofluorescence, IAF was negative in case of minimal change disease, right? And here the IIF, there will be a mesangial positivity. Mesangial positivity. Okay, the characteristic finding is mesangial positivity. As a linear positivity in which disease? Remember, Gold-Pasha syndrome. There are granular positivity in which disease? Membranous glomerulonephritis. Okay, I guess you are getting this. The post-focal PSGN also there is your granular positivity, right? You can see here granular positivity in PSGN, lumpy bumpy appearance was there, and IAF was negative in which one? Minimal change disease. IAF for mesangial positivity in which disease? IgA nephropathy. Because if you understand the pathogenesis, then it's very easy to do this. Then comes electron microscopy. Electron microscopy again, there is increased density in mesangium. There is increased density in mesangium. Okay, there's dark deposits present in the mesangium. Okay, so it's very easy. Okay. Electron microscopy, there is an increased density. Increased density you can write dark deposits. In mesangium. Understood? Got it? So we finished your IgA nephropathy as well. Okay. Then we are going to the MPGN spectrum of diseases. MPGN spectrum of diseases, where we have categorized it into MPGN type 1 and C3 induced glomerulonephritis, out of which this C3 induced glomerulonephritis has a subtype known as MPGN2. So MPGN 1 is there, and MPGN 2, which is the subtype of the C3 induced glomerulonephritis. We have to read these two important disorders as well as lupus nephritis and RPGN. Okay, so MPGN type 1. So MPGN stands for, first earlier it was told mesangio capillary, right? Mesangio capillary glomerulonephritis, but now it is called mesangio proliferative, mesangio, sorry, membrano proliferative glomerulonephritis. Remember this, membrano proliferative glomerulonephritis. Okay, okay. So MPGN type 1, it may be again of two etiologies. Either it may be primary etiology, okay, where the most common cause is lupus nephritis itself, okay. This is not separate entities, this may be associated entities. But I have separated this for the ease of understanding this, okay. So it may be of a primary etiology, like an immunological kind of etiology, or your can say idiopathic cause, okay, or it may be secondary etiology. Secondary also it can be lupus, it may be associated with alpha 1 antitrypsin, okay, HPC, or it may be associated with any other malignancies, right? So etiologies are two. Etio. It may be a primary etiology, it may be a secondary etiology. So primary etiology is an immunological etiology. Immunological etiology, where the lupus nephritis is the most common. Lupus nephritis, it is the most common, or it may be associated with some conditions it may be like unknown. Okay, it may be of unknown cause, idiopathic. Then it may be of secondary that in okay. Another thing is that in primary etiology there is an activation of classical pathway as well as alternate pathway. There is a activation of classical and alternate pathway, and there is capillary damage associated with this disorder in the primary etiology. But in then your if classical pathway, okay, if classical pathway is activated, there is capillary damage, but if alternate pathway is affected, there is mesangial damage. But we saw, right, in alternate pathway, wherever there is activation here in this IgA nephropathy, wherever there is an activation of the alternate pathway, there was being mesangial damage associated. And wherever the classical pathway is affected, here look at this, in this condition, where the post-streptococcal glomerulonephritis, where the classical pathway was being your activated, okay, here antibody production or classical pathway was damaging the capillaries, the sub epithelia, or any capillary damage is seen. Okay, understood? So there is in damage to both capillary as well as mesangium, damage to both capillaries as well as mesangium. Okay, we'll see the microscopy as well, will be clear. Idiopathic. So here in secondary causes, there may be secondary etiologies. There may be associated with some malignancies. There may be association with alpha 1 antitrypsin. There may be association with your hemophilia B or C, hemophilia B or hemophilia C. Okay, there may be association with lupus also. Anything. Okay. So what is the pathogenesis? So pathogenesis is very simple. There is a damage to both. Let's write patho first. I believe that you all are making notes with me. This beautiful spectrum of notes is being made. and this all this hard work is for you only. And I hope you are drawing this side by side in your notebook as this chart. Okay, and this chart will cover all the aspects of pathology of the glomerulonephritis. And this is there in medicine as well. In medicine, you will read this, but this pathogenesis, this small things, this deposition, this IAF, microscopy, all you get confused. So that, but if you revise this in a consolidated way, then it is very easy, right? So, talking about the pathogenesis here, what is the pathogenesis? So, there is a damage to both capillary as well as mesangium. Therefore, it was earlier called mesangiocapillary glomerulonephritis, right? Mesangiocapillary glomerulonephritis. Now it's called membranoproliferative. Okay. So, basically, what is happening? Let's say this is a capillary. So, first point you write the damage to capillary plus mesangium. So let's say here some capillaries are present. Okay, some capillaries are present, and this background is a mesangium, right? This is a mesangium. Okay. Okay. So what happens is that due to the inflammation and fibrosis, this mesangium will condense. Due to this inflammation and fibrosis, this mesangium will condense and crack. Okay, it will be a condensation and cracking of the mesangium. Okay, the mesangium is made up. It is a semi-solid material. It is made up of glycosaminoglycans. This mesangium is composed of GAGs. Okay, so it is due to inflammation and fibrosis. So here, inflammation and fibrosis, this mesangium cracks due to the etiology. In this inflammation and fibrosis is due to the etiological agents, right? So mesangium will crack, and there will be compartmentalization of the mesangium. Okay, so let's see is the glomerular basement membrane. Okay, let's say this is the glomerular basement membrane, and this is the mesangial side, and this is the luminal side. The mesangial side, this is the luminal side. Okay, so what will happen is that the glomerulus will be GBM will be damaged, and there is the podocyte damage as well. Okay, the glomerulus damage is there, the podocyte damage is there, the endothelial damage is there. Okay, and a new layer, this glomerular basement membrane, the new layer of collagen will be deposited over the cracks. Okay, new layer of glomerular basement membrane will be deposited on the cracks, which is called as the tram track appearance. A train like track appearance is there, tram track appearance, or the splitting of the basement membrane. Okay, and in the microscopy, what you will find, there will be mesangial and endocapillary hypercellularity. Endocapillary hypercellularity was also seen where? Also seen in post-streptococcal glomerulonephritis. There was in the PSGN, there was endocapillary hypercellularity. Okay, and here also there will be and capillary. Mesangial hypercellularity was present where? Mesangial hypercellularity was present in IgA nephropathy. Present in IgA nephropathy. So here there will be mesangial and endocapillary hypercellularity will still be present. Okay, so that is the thing. And okay, inflammation fibrosis, mesangium will crack, and this mesangium, the mesangial side of the GBM will be damaged. Mesangium crack, GBM damaged. This becomes like this. Okay, and a layer of collagen is deposited over it as fibrosis is there. Okay, new layer of collagen deposited. A new layer of collagen is deposited over here, which is called as a tram track appearance. This is a characteristic line which you have to remember. A tram track appearance. Okay. the tram track appearance. Done. So that was about the pathogenesis of your MPGN type 1, right? And the podocytes are also damaged. There is podocyte damage also. So in your microscopy, in your light microscopy, what you'll see, you will see in the light microscopy, you will see there is a mesangial and endocapillary hypercellularity which will be associated. So first thing is the tram track appearance or splitting of basement membrane, splitting of basement membrane, or your tram track appearance. And the second thing you will observe is the hypercellularity, the endocapillary and mesangial hypercellularity. Endocapillary and mesangial hypercellularity. Okay, and immunofluorescence, again you will see there is a hypercellularity in a patchy format, right? There's a hypercellularity in patchy format. IgG and C3 are deposited in the wall. Also it is deposited in the mesangium. Also it is deposited. So deposition occurs in every part. So you can remember like this. It is a granular immunofluorescence. So immunofluorescence, IAF, this granular positivity. Understood? Granular positivity. Okay. And electron microscopy, again, electron microscopy will be like the lupus only. Okay. There will be that deposition in all parts. Okay. Deposition in uh, like in nearly all parts. Okay. There's a, you can say, why the lupus, when we see the lupus, you will appreciate it much. Okay. Now you can like fluent. Okay. So deposition is occurring. There is an endocapillary mesangial hypercellularity. So there is increased density. You can write here. You can just easily write here. Increased density in mesangium and endocapillary. Electron density more inside capillaries. Logical? Okay. Next, we will come to our important thing, that is lupus nephritis. That is lupus nephritis. So, lupus nephritis will cause a characteristic hairpin loop lesions. I will tell you about that. And here, the classification of lupus nephritis is given. We'll see the classification of lupus nephritis as well. Classification is not much important from your point of view. It is not much aspect. If you get a short note in lupus nephritis, you must have to deal with it. And PG entrances, this all parts are there. So lupus nephritis is often that not that much important. In medicine, you will read more and more aspects of this. Okay. Okay. Let's move on to the next part. Okay. On to the lupus nephritis. Lupus nephritis is basically a damage due to any organ. Okay, due to any organ, due to this hairpin shaped vessels. Some vessels are there which is shaped like a hairpin, like this. Okay, shaped like this. It's a hairpin shaped vessel. So lupus nephritis is a disorder due to which the immune complexes, let's say, if let me make you understand here only. Okay. Next, this is a hairpin shaped vessel. So, at the top of the vessel, there will be a sluggish blood flow. There will be a decreased velocity. You know, whenever there is a circular motion, there is a decreased velocity at the topmost point. So, there is a decreased velocity at the topmost point, due to which there is a vascular stasis. Okay, due to vascular stasis, some immune complexes are deposited here. And it leads to lupus nephritis. Okay. Understood. And what are the areas which are affected? The glomerulus is affected. Your vasa recta is, yes, they are affected. Arcuate vessels are affected. Okay. So this lupus nephritis, in special point, I am going and writing special point. So it can affect just affects glomerulus. It can affect your vasa recta. Vasa recta, is a hairpin shaped vessel, right? And your arcuate arteries. Arcuate arteries are the interstitial arteries that are present in the at the part. Understood. So etiology is simply vascular stasis. Okay, etiology is simply vascular stasis. Okay, no such etiological importance is there. The pathogenesis you can sorry. The pathogenesis is this is a hairpin shaped vessel. So there is a vascular stasis and there is deposition of immune complexes. Deposition of immune complexes. Okay, understood. So this is called as lupus nephritis. Actually, what happens is that the deposition in first one in the class one, we'll see some 6 classes of lupus nephritis are there. Okay, so in class one lupus nephritis, the deposition is just like this in a this format. Just see, deposition is like this only. This is class one LN lupus nephritis. In class 2 lupus nephritis, it will expand. It will expand below and downwards. Okay, it will expand. Expand in class 2. In class 3 lupus nephritis, it looks like a complete damage. Class 4 onwards, okay, it is called as a wire loop lesion. It is called as a wire loop lesion. As you go on, the deposition will expand and expand and expand. So this is called, this type of lesion is formed. This is called a let's say this is the class 4 one. So class 3 and 4 specifically we see, but class 4 is more predominant. Class 4, this is called as a wire loop lesion. Wire loop lesion. This wire loop lesion word is important. Okay, highlight. Done. And the membrane now then complete damage is seen in class 5 one. The whole circle is damaged. Okay, so class 5 is whole circle damaged. Okay, just see, is complete damage class 5. Okay, so these are some of the classes of lupus nephritis. Okay, uh, we'll name the classes now in the special point section, but let's first move to the microscopy. Okay, so again, the microscopic finding is just the same. This parts have been considered in microscopy as well. Okay, microscopy basic. You just do one thing to bring this part to the microscopy. Okay, so class 5 is a complete damage. It's a class 5, and class 3 and 4, class 3 and class 4 LM, we see some wire loop lesions. Wire loop lesions. Okay, so you will see a deposition there. And after class 5, class 6 is direct sclerosis. There will be sclerosis of the whole vessel, right? So this is the vessel even. Okay, don't get confused. What is this? This is a vessel. Understood? So that was about our lupus nephritis, the pathogenesis, the microscopy of lupus nephritis. No such point is there in the etiology. Okay. Next we come to the immunofluorescence. Immunofluorescence. So immunofluorescence, what happens is that in immunofluorescence, we say that what are the things which are positive here. Okay. What are the things which are positive here? So here IgG is positive, IgA is positive, C1q is positive. Okay. C3 is positive, your kappa and lambda are also positive. Okay, all you do positive. Okay, all you do positive. then subendothelial deposits will be seen. Okay, there will be immunofluorescence positivity. So immunofluorescence IIF, I told you that do all positive. IgG is positive, IgA is also positive. IgG positivity, IgA is positive, C1q is positive, okay, kappa is positive, lambda is positive, okay, all are positive, and C3 also, C3 is positive. Done. Okay, this is about immunofluorescence. And talking about your electron microscopy, so there are subendothelial electron density. Why? Because it is occurring beneath the endothelium, right? It is occurring beneath the endothelium. So there is subendothelial deposits. Okay, that is, mm, yeah. So in electron microscopy, sorry, subendothelial deposits present. Subendothelial electron density or subendothelial deposits. Okay, and this is seen in your lupus nephritis. Okay, and talking about the classes, so it has specific names. So classes of lupus nephritis. Give the heading classes in special point classes of lupus nephritis. Let's see the classes of the lupus nephritis. So in classes, we will observe that we have 6 classes. Classes are 6 in number. It is very easy to remember the name. Okay, so class 1 is your minimal mesangial lupus nephritis. Okay, class 2 is your mesangial proliferative lupus nephritis. Class 3 is focal lupus nephritis. Class 4 is diffuse lupus nephritis. Class 5 is membranous lupus nephritis. And class 6 is advanced sclerosis lupus nephritis. Okay, so these are the stages. So first one I told, class 1, 6 classes. So class 1 is a minimal mesangial lupus nephritis. Minimal, it is very less. Minimal mesangial lupus nephritis. Done. Minimal mesangial lupus nephritis. Then it proliferated, it spreaded, right? So mesangial proliferative lupus nephritis. Mesangial proliferative lupus nephritis. Done. Third one is called as a focal lupus nephritis. Focal lupus nephritis. So there is the involvement of less than 50% of the blood vessel is involved. Okay, so less than 50% involvement is present over here. Then class 4, the diffuse lupus nephritis. Here more than 50% involvement is there. More than 50%, and this is the most common. Remember, this is the most common stage. The most common stage. Okay, then class 4 is done. Class 5. Class 5 is called as the membranous lupus nephritis. Membranous lupus nephritis, and class 6 is called as advanced sclerosis lupus nephritis, because here the blood vessel is completely sclerosed. Let's say this is the blood vessel. The blood vessel is completely sclerosed. Understood? So that was about the classes of the lupus nephritis in the special point section. So that much things you have to understand in lupus nephritis. Okay, and now we are moving to the MPGN type 2, which is also under the membranoproliferative glomerulonephritis type 2, which is a subtype actually, which is a subtype of the C3 induced glomerulonephritis. It is also called as the dense deposit disease. It is also called as the dense deposit disease. Dense deposit disease. Okay. Dense deposit disease. Okay. So etiopathogenesis is that the problem is there in your C3 nephrotic factor. Okay, the C3 nephrotic factor actually, the what happens is that, just uh, listen to me first. There is something such as factor I and factor H. Factor I is present and factor H is present. This factor I and factor H actually, in normal conditions, in a normal body, destroys the C3 convertage. If you have read the complement pathway, the C3 convertage is the one which is converting the C3 to C3A plus C3B. Okay, so this is destroying the C3 convertage, due to which there is no complement activation. Okay, there is no complement activation. Understood? This is the basic mechanism. C3 nephrotic factor is stabilizing the C3 convertase. Okay, so if there is increase in this C3B is inhibiting the C3 convertase, the byproduct basically. Okay, if there is excess, everything of excess is bad, right? So if there is excess of C3 NEF, that is C3 nephritic factor, okay, then it will cause your either this is the problem, or if there is a loss of function of factor I and factor H, then there is an overactive alternate pathway. There is an overactive alternate pathway, and the complement proteins are basically starting to accumulate here. Okay, there is a mesangial positivity again. Okay, then we'll say how we will differentiate it from IgA nephropathy. How will differentiate? Because IgA nephropathy was also the same thing. Okay, and this is also, you are saying that same thing. But remember, IgA nephropathy had IgA also present, right? But here there is no IgA. Okay, here there is no IgA. Okay, so this absence of IgA is the thing, and electron microscopy is basically an intramembranous dense deposit, due to which it is called as the dense deposit disease. Intramembranous dense deposit. Why it occurs, how it occurs, we don't know clearly, but it is a dense deposit disease, and intramembranous electron deposition is basically occurring. Okay, and it has a bad prognosis. And this or previous ones have a slightly good prognosis, but this one has a very bad prognosis as compared to this. Okay. About many things will happen if this happens. Okay, so whatever I told, let's write. Whatever I told is all about your MPGN type 2 or type C3 induced glomerulonephritis. So etiopathogenesis is basically the C3 nephrotic factor. Okay, so basic thing which is happening, is this. Just start with factor I and H. Factor I and H. This factor I and H are basically, what are they doing? They are just inhibiting the C3 convertase, and the C3 convertase is was the enzyme converting C3 into C3A plus C3B. Okay, and here the stabilizing factor, the C3 convertase is stabilized by the thing which is called as a C3NEF. Okay, C3NEF, that is, what is C3NEF? C3 convertase nephrotic factor. C3 convertase, sorry, nephritic factor. Pardon me, nephritic factor. Okay, this was stabilizing it. Okay, was stabilizing it. So this is the etiopathogenesis. Okay, but the pathogenesis, how the disease is occurring, is basically what happens is that the pathogenesis, it can be of two types. Any problem may be there. Either it is a increase in the C3NEF, increase in C3NEF, which may be causing this, or if there is a loss of function of factor I and factor H. Factor I and factor H. Either there is an increase in C3NF or a loss of function of factor I or factor H, due to which this both pathogenesis will lead to increase overactive alternate pathway, overactive overactive alternate pathway. And if there is an overactive alternate pathway, what is the syndrome? Nephritic syndrome. Nephritic syndrome will be occurring here. Let's take pink as we're maintaining the color coding. If I have been observing, it will be a nephritic syndrome. Okay, and what will be the microscopy? Basic microscopy. So microscopy will be a mesangial expansion or a mesangial hypercellularity, because of course this mesangial deposits will be present. Alternate pathway activated means C3 and C5a will come to the mesangium. Okay, so microscopy will be again mesangial hypercellularity, which is same as in Burger's disease or IgA nephropathy. Okay, so mesangial hypercellularity and mesangial expansion. Mesangial hypercellularity or mesangial expansion, and how you can differentiate it from your IgA nephropathy, that it has no IgA. Okay, simple. And electron microscopy, what about the electron microscopy? Electron microscopy, there will be intramembranous dense deposits present. So the immunofluorescence, right? First, okay. Electron microscopy here. So there will be intramembranous. Intramembranous dense deposits present, and immunofluorescence. Again, just like your IgA nephropathy, mesangial positivity. Mesangial positivity. Are you understanding? Okay. And this has a bad prognosis, so which I can write in the special point. This has a bad prognosis. Okay, this has a bad prognosis, and treatment is simply transplant. Okay, but 85 to about 90%, you can say, transplant are rejected. Okay, and it recurs. Okay, so there is no treatment till date. Okay, you can do transplant treatment aspect, you can do transplant, but recurrence occurs in 85 to 90% cases. You can do transplant, but recurrence will occur in 85 to 90% cases. Okay, and this there may be many outcomes are there. Okay, there may be any complications. Okay, there may be MGN, there may be IgA nephropathy, there may be MPGN type 1, lupus nephritis, MPGN type 2. It can progress to anything. It may cause kidney injury, it may cause acute renal failure, it may become chronic, and the patient may develop the end stage renal disease. Okay, so that may be the outcomes. And now let's talk about rapidly progressing glomerulonephritis. Okay, let's start with RPGN, that is rapidly progressive glomerulonephritis. RPGN stands for rapidly progressive glomerulonephritis. Okay, so it is an acute problem. It is not chronic problem. It is an acute problem, and as expected, there are no such you know I can say. Problem etiological agents, so like that. Okay, it is just a endogenous infection. Endogenous means it is just a problem in the body itself. Okay, there are no such etiological agents which will be causing this that infection. So pathogenesis is that there will be a glomerular basement membrane rupture, due to which there will be fibrin clot forming. Okay, a fibrin clot will form and irritate the parietal epithelial cells. Okay, so there will be, if there is an irritation, there will be proliferation. Wherever there is a destruction, there is reformation. Right, like that you can understand. So there is a proliferation of the that parietal epithelial cells. WBCs will enter the Bowman's capsule, fibrin will be present, and also visceral epithelial cells will be present. Okay, so it looks like a crater. Okay, crescentric shape is formed, and this crescentric shape, due to this crescentric shape, this RPGN is sometimes referred to as crescentric glomerulonephritis, also known as crescentric glomerulonephritis. Why? It is called as crescentric glomerulonephritis because it looks like a crescent, that a moon-like shape. Okay, the cell proliferation is in that pattern. Is that it looks like that, right? So the what are the types? Okay, three types of RPGN are there. Type one, okay, type two, and type three. And these types are on the basis of the immunofluorescence. These types are on the basis of the immunofluorescence, and based on that we have the categorization. Okay, based on that we have the categorization, and electron microscopy will simply reveal a broken basement membrane. Electron microscopy is just nothing, as simply broken basement membrane. And how you can treat it? You just do hemodialysis. You just do hemodialysis. Okay, there are you don't need to go into much detail into the things. Okay, let's talk about pathogenesis, and then we'll talk about how the microscopy appears. That is a crescentric shape. Okay, then we'll talk about immunofluorescence. Immunofluorescence, on the basis of immunofluorescence, we classify it into three types. Either it may show granular immunofluorescence, or it may show a linear pattern, or it may be a posse-immune pattern. I will tell you that posse-immune. Posse-immune means no immunofluorescence. That is negative. Okay. So that is a posse-immune pattern, and other things. Okay. So based on that, the things are there, and we have to remember or understand it. Okay. So let's start with the thing RPGN. So ETU is not much there. Okay, etiology is a basement membrane rupture, a basement membrane rupture, and due to this basement membrane rupture, what happens? A fibrin clot is formed. Let's say this is the blood vessel. Let me draw it in red. So here, a fibrin clot is formed. This is a clot, a fibrin clot. A fibrin clot is formed, and this fibrin clot irritates parietal epithelial cells. So this is the main etiology. Talking about the pathogenesis, what is the pathogenesis? Let me state you. So pathogenesis is basically due to this irritation to the parietal epithelial cell. There is an proliferation of parietal epithelial cell. Proliferation of parietal epithelial cell, and due to this, as there's proliferation, as destruction is also there. So WBC's infiltration will also occur. WBCs will increase in number here. Okay, in the localized WBC, they will enter the Bowman's capsule and increase in number. Fibrin will be present since a clot is there. Fibrin is present. Okay, and since the visceral epithelial cells will also be seen. Okay, visceral epithelial cells will also be seen. Okay, that is about your thing which is occurring. Okay, so what happens is that this type of thing, this is the mesangium, the capillaries in a cross section view, and the mesangium here, and due to this the excess proliferation, there is destruction of a part, and the formation is like a crescent, a moon like appearance. Okay, if I talk about the microscopy, it will look something like this. It will The fibrin meshwork will be there, and the cell proliferation will also be there. Okay, the parietal will proliferate like this. Parietal cells will proliferate. These are the parietal cells. Okay, these are the parietal cell proliferation. There will be parietal cell formation, proliferation, and here the red things are fibrin meshwork, and these things will destroy half of this. Will destroy this part. Let's say this will destroy this part. So it looks like a crescenter, a moon-like shape, and this is called as crescentric glomerulonephritis. Crescentric glomerulonephritis. Okay. So that was about our microscopic findings. And on the basis of immunofluorescence, I told you we have three types. We have three categories: the type 1, type 2, and type 3. Based on this, either we can have either we can have a linear immunofluorescence. Okay, so linear immunofluorescence, this is called as type 1. Linear immunofluorescence may occur type 1. Okay, such as example is Goodpasture syndrome. Okay, linear immunofluorescence is seen in Goodpasture syndrome. Second, granular immunofluorescence, so we tell it type 2. Granular immunofluorescence is seen in PSGN, post-streptococcal glomerulonephritis. Then think. MPGN type 1, yes. IgA nephropathy also, yes. Dense deposit disease, that is MPGN type 2, yes. Lupus nephritis also, yes. Granular immunofluorescence. Linear, just one example, Goodpasture syndrome, right? And third one is a posse immune. Posse immune means no immunofluorescence. No immunofluorescence. It is called as type 3. Type 3. And the examples are Wegener's granulomatoma, okay, Wegener's granulomatoma, and microscopic polyangiitis. Wegener's granulomatoma and microscopic polyangiitis. Okay, these are the examples of posse immune conditions. Okay, and the electron microscopy will reveal a broken basement membrane only. That is the feature. We'll see. Just a minute. Broken basement membrane. Okay, and if I talk about some special points, then the treatment is hemodialysis. First point, treatment is hemodialysis. Treatment is hemodialysis. Understood? Done? Okay. So that's all we have to understand. As per the glomerulonephritis is concerned, the spectrum of glomerulonephritis is concerned. Okay, that is the whole. This is the whole table which will clear all the problems, all the questions, all the theory of glomerulonephritis. If one comes in your exam, then you can write in sequence. If compare and contrast comes, you can write this. You can, if it is easy to remember in that format also. In one page, you have done with all. Okay. Why it is important? Like this is a book. Okay. This is a book. Okay. Here in glomerulonephritis, there are 10 pages. You are thinking about the exam that I have 10 pages to read from here, 10 pages to read from there, etc. But if you have one chart to read, it is very easy. Okay. You will see, yeah, one chart to read. How much time it will take? 30 minutes max. 40 minutes, 30 minutes max. Yeah. After multiple revisions, you'll find 10 minutes, 20 minutes at most time will take. Okay. Another thing which I want you all, which I want to discuss with you all, are the complications of glomerulonephritis. So, if this much space is sufficient for the complications, just a minute. Let me color it first. Okay. We'll use this much space and talk about some of the complications of glomerulonephritis. Complications. So complications, you will say that there is another type of glomerulonephritis which was called FSGS. FSGS means focal segmental glomerulonephritis. What happens is that whenever there is a capillary present over here, like this is a glomerulus and the capillary is present, mesangium, capillaries are present, the foot processes are damaged. So if there isn't any damage, okay, so what will happen? There will be healing by fibrosis. But if there is repeated damage, there will be healing by fibrosis. Okay, healing on repeated damages. There is a severe damage. There is a complete damage. Just a minute. Okay, there will be a complete damage like this. There is a complete damage. Okay, so like this, the glomerulus some are good. Okay, somewhat damaged. So if this is a section, like this is normal, this is half damage, this is complete damage, this is complete damage. So this is a focal disease. This is a focal disease. Focal disease. It is not a complete. It is not a global disease. So on microscopy, it is a segmental format. So it is a focal disease. It is not a global disease, and this is called as FSGS. That is focal segmental glomerulonephritis. Focal segmental glomerulosclerosis, not nephritis. Glomerulonephritis is finished. This is a complication, right? It is a focal segmental glomerulosclerosis. Okay, I'm writing the name. Importantly, focal segmental, derived from the name itself, glomerulosclerosis. Okay, and here it is the most common, importantly, remember, it is the most common microscopic finding in CKD patients. This is the most common microscopic finding in the CKD patients. This is an important statement. Okay, this is an important statement. Most common microscopic finding in CKD patients. Okay, and CKD is classified on the basis of GFR only, you know. And here in this case, there will be nephrotic syndrome associated with it. Which syndrome? Nephrotic syndrome. Nephrotic syndrome. There will be no hematuria. Nephrotic syndrome associated with it. Okay, this much thing you know. Okay, after that, let's talk about the etiology. Okay, etiology. So etiology, it may be a primary FSGS or it may be a secondary FSGS. So this FSGS also, talking about etiology, it may be a primary type or it may be a secondary type. So what are the primary etiologies? So primary etiologies basically, we'll see that it is a mutation related condition. It is a mutation related condition, and the most common mutation here occurs in the chromosome number 19, that is nephrin mutation. Most common is the nephrin mutation. Nephrin mutation. Nephrin mutation. Okay, and this is Finnish type of mutation. Finnish type. Finland is a country, right? So it is Finnish type of mutation, and this nephrin mutation on chromosome 19. On chromosome 19, and this is called as a congenital nephrotic syndrome. A congenital nephrotic syndrome type 1. Okay, this is called as congenital nephrotic syndrome type 1. Understood? Then we have something called this CNS. I am writing CNS for syndrome, congenital nephrotic syndrome. So we can have also CNS type 2. CNS type 2 is also there. CNS type 2 is due to the podocin mutation on chromosome number 1. Podocin mutation on chromosome 1. Podocin mutation on chromosome 1. Or we can have TRPC protein defect or apolipoprotein L1 polymorphism. Okay, it may be of TRPCE protein defect, or it may be due to the mutation or the apolipoprotein L1 polymorphism. Morphism on chromosome 22. Okay, this may occur, and this most commonly present in childhood, and these are the steroid resistant. Steroid won't work for this. Okay, steroid won't work for this. Understood? And another thing is the secondary FSGS, which may be associated with conditions, any medical renal disease, like any glomerulonephritis. It may be associated with any glomerulonephritis. It may be associated with diabetes mellitus. It may be associated with hypertension. Okay, and these are the things, and it may be associated with renal ablation. Renal ablation may be associated with renal ablation. Renal ablation means removal of a kidney. The another kidney will burn out and cause this. Okay, and a subtype is called as a collapsing variant of FSGS, which is seen in HIV, and this is the worst prognosis. Okay, there is a collapsing variant of FSGS, which is seen in HIV and has the worst prognosis. This question is asked. That's why I am telling you. Was asked. So we have something called as a collapsing variant of FSGS, okay, which is seen in HIV, and this has the worst prognosis. Okay. Classification is called as the Columbia classification, which you don't need to retain or remember. Okay. And here in collapsing variant, basically there is a glomerular necrosis and the mesangiolisis will occur. The mesangium will lyse perfectly. This is out of our scope, and this much is important. Just for this question part, I told you this. Okay. So this is the complications of glomerulonephritis, and with this, congratulations, we finished glomerulonephritis in one sheet of paper, and this one sheet of paper can decide your future, as in contrast with the basic idiom. That's all in today's lecture. Let's meet again in another lecture. Till then, bye bye. Take care, and good afternoon.